In this next section, we will review some specific strategies related to the management of the ventilator in patients suffering from status asthmaticus. We will discuss the concept of permissive hypercapnea, the management of patients with ARDS, and finish with the review of acute ventilatory failure. Patients who require intubation in the setting of status asthmaticus can be quite complicated, and first and foremost, we must maximize medical therapy, which generally includes continuous nebulization of albuterol and ipratropium bromide, the delivery of IV steroids, consideration of IV magnesium, but not the routine administration of chest percussion therapy, not the routine delivery of N-acetylcysteine, and not the routine use of antibiotics unless you believe the patient has a coexistent bacterial infection. Prior to intubation, one could consider the use of Heliox as a way of decreasing the work of breathing long enough for the various medical regimens to exert their efficacy. However, its role is somewhat unclear. Patients who are intubated in the setting of status asthmaticus will frequently demonstrate extremely high peak pressures, which are unavoidable, since any breath that is delivered will almost certainly have quite delayed expiratory time associated with it, leading to the development of autopeep. Hence, we will accept high peak pressures in an attempt to minimize autopeep. To do this, we will usually use a higher than typical flow rate, remembering that the normal flow rate is 60 liters per minute, and as I said, accepting high peak pressures. You would like to avoid the co-administration of neuromuscular blockers with steroids in these patients, as the risk of post-blockade neuromuscular weakness is high. In most patients requiring mechanical ventilation, and specifically in patients with status asthmaticus, we will consider implementing a strategy referred to as permissive hypercapnea. The concept behind permissive hypercapnea is that we would, of course, like to maintain a normal CO2 and pH in patients, but that in some patients, their lung mechanics would require excessive peak pressures in order to achieve normal PCO2s. These peak pressures could themselves lead to worsened lung injury. Hence, we will often allow the CO2 to rise in order to avoid implementing ventilatory strategies which could increase the risk of barotrauma. So rather than imposing high peak pressures, we will accept hypercapnea with the goal of minimizing the risk of barotrauma and reducing the risk of ventilator-induced lung injury. As the PCO2 rises, the pH will be expected to drop, and at some point, physicians may implement a bicarbonate drip in order to avoid unacceptably low pHs. Regarding ARDS, the definition requires severe hypoxemia as assessed by the PF ratio. The PF ratio, you take the patient's PO2 divided by the delivered FiO2, and any ratio less than 200 is severe enough hypoxemia to qualify as ARDS. In order for the patient's hypoxemia to be attributed to ARDS, there must be a diffuse chest X-ray abnormality and no suggestion of heart failure as the underlying etiology. Most all of these patients will have reduced compliance as well. In terms of treatment, you would of course treat the underlying cause. We're going to give them supplemental O₂, diurese the patient, administer PEEP, optimize the mixed venous PO2, and consider prone positioning, with additional considerations being the implementation of ECMO. In terms of treating the underlying cause, the three most common causes of ARDS are pneumonia, sepsis, and aspiration. And while there are a number of other etiologies, each of these are individually uncommon. Furthermore, it is important to recognize that in a third of cases, we are unable to identify a specific cause of ARDS. These patients are dying of hypoxemia, and hence it is reasonable to deliver supplemental FiO2, and we almost always do in patients with ARDS. But it's important to remember that the etiology or mechanism of hypoxemia in ARDS is shunt, and that shunt is poorly responsive to supplemental O₂. And the use of high levels of FiO2 can lead to oxygen toxicity. As illustrated here, A patient with ARDS would have an alveolus that is full of hyaline membranes, edema fluid, and inflammatory mediators, such that none of the FiO2 delivered down the endotracheal tube is actually going to make its way into the capillary bed in that region. Hence, the patient's mixed venous O2, typically 40, would leave as an arterial O2 of 40. And no matter how much FiO2 is delivered down the endotracheal tube, no more will reach this capillary bed. In this situation, one should not use a toxic level of FiO2 unless doing so actually does improve the arterial oxygenation. In patients who have ARDS, the primary problem is leaky capillaries, such that fluid in the capillary leaks out of the capillary and into the alveolus. And anything we can do to reduce the driving pressure in the capillary may reduce the amount of alveolar edema fluid formation. Hence, we diurese patients with ARDS. Regarding PEEP, titration of PEEP is a bit of a challenge without clear-cut consensus as to how PEEP should be adjusted. The good things PEEP does include recruiting alveoli, redistributing pulmonary edema, and increasing the arterial O2. The bad thing is that PEEP reduces venous return and potentially cardiac output and can increase the risk of barotrauma, raising the question, how much PEEP? This photomicrograph shows on the left alveoli of a mouse with ARDS, where the alveoli are full of pink edema fluid. With the application of PEEP, one can see that the alveoli are now open, which would imply improved gas exchange. Occasionally, physicians express concern that adding external PEEP will lead to increases in auto-PEEP. However, this is not commonly the case, as illustrated in this waterfall model, where fluid approaching a waterfall will fall at the same rate, regardless of how high the downstream water level may be, unless that downstream water level exceeds the upstream water level. In terms of reducing PEEP in patients with ARDS, a 3-minute PEEP trial is often recommended. In a 3-minute PEEP trial, the patient is assessed on the existing level of PEEP with an ABG sample drawn. PEEP is then decreased by 5 centimeters of water for a period of 3 minutes, at which point a second ABG is drawn and the PEEP is immediately returned to the preceding level. If the difference between the two ABGs in terms of PO2 is minimal, it implies that the patient did not actually need the previous level of PEEP, and one may safely reduce to the second level of PEEP. Managing patients with ARDS can be complicated, and one of the strategies to improve arterial oxygenation is to improve the mixed venous oxygenation. This can be done by assessing simultaneously the patient's oxygen consumption and net oxygen delivery. Oxygen consumption can be reduced by treating fever, reducing work of breathing by putting the patient on ventilator settings that are comfortable, sedating the patient, treating any coexistent pain, and even paralyzing the patient to completely eliminate all skeletal muscle oxygen consumption. Oxygen delivery is governed by the equation DO2 is equal to cardiac output times oxygen content, and oxygen content is equal to the amount of oxygen bound to hemoglobin plus that which is dissolved. Hence, one could consider using inotropes to increase cardiac output, which would increase oxygen delivery, as well as transfusion to increase oxygen carrying capacity. Prone positioning has been advocated in extreme situations of ARDS-related hypoxemia. As illustrated in this CT scan, this patient with ARDS has dependent parenchymal lung zones that are densely consolidated, middle lung zones that are moderately diseased, and ventral lung zones that are relatively preserved. Unfortunately, in the typical supine positioning, gravity sends the majority of blood flow through the worst lung zones, worsening shunt. If one were to flip this patient into the prone position, then gravity would now send blood flow to the relatively normal alveoli and potentially improve oxygenation. As seen here in a landmark study by Gattinoni in the New England Journal of Medicine in 2001, you can see dramatic increases in PO2 on a day-to-day basis when patients were flipped to the prone position. Unfortunately, it is difficult managing patients in the prone position regarding access to their ET tube, Foley catheters, and other catheters, and the benefit of flipping to the prone position is transient. However, it is something to consider in patients with refractory hypoxemia. Hence, treating ARDS is complicated, but includes treating the underlying cause, adjusting FiO2 even to toxic levels if doing so is necessary to maintain a satisfactory PO2, diuresing the patient even though the underlying problem isn't volume overload, increasing levels of PEEP, attempts to improve the mixed venous oxygenation by consideration of inotropes and/or blood transfusion, and occasionally considering prone positioning. Finally, while not included on a slide, one may consider the utilization of ECMO in unique scenarios. Finally, we will address the specific management of patients with acute ventilatory failure, the patients who get intubated because of an imbalance between the load on the respiratory system and the patient's respiratory system strength. These patients are identified either because they have already developed ventilatory failure and they are hypercapnic, or more commonly, they are patients who are eukapnic but have evidence of increased minute ventilation requirements or increased work of breathing. Keeping in mind that our arterial CO2 depends upon CO2 production divided by alveolar ventilation, and that alveolar ventilation depends upon total minute ventilation corrected for dead space ventilation, one can see that hypercapnia can develop from only 3 mechanisms. One could have increased CO2 production, which is extremely rare and never is a cause of hypercapnia independently, in that patients who have excess CO2 production will typically simply ventilate more in order to compensate. Hence, for excessive CO2 production to lead to hypercapnia, there would need to be coexistent limitations on the patient's ability to increase their alveolar ventilation. Hypercapnia can be caused by decreased total minute ventilation, which is usually easily recognized. So if the first cause is rare and the second is easily recognized, don't forget about the third mechanism of hypercapnia, which is increases in dead space. The concept being that if more of each tidal volume is wasted, then effective ventilation will be reduced. VDVT, or dead space, is that section of the lung which is being ventilated but not being perfused. Dead space can be divided into anatomic dead space, i.e. the trachea and bronchi down to the respiratory bronchioles, which typically is a volume of about 1 cc per pound. This is a mistake. This is 1 cc per pound. So in a 70 kilogram or 150 pound male, that would represent 150 cc's out of a typical 500 cc tidal volume. So roughly 30% of a typical tidal volume is anatomic dead space. Physiological dead space could be found in zone 1 of the lung regions, i.e. the apices, where there is decreased perfusion relative to alveolar pressures, so that these areas are still being ventilated, but they are not being perfused. This could be exacerbated in settings of volume depletion or in settings which would increase alveolar pressures. Finally, you can also develop physiological dead space due to vascular disease, such as seen in pulmonary hypertension or pulmonary embolism. In terms of categorizing acute ventilatory failure, increased load can be due to increased resistance, increased respiratory system elastance, or conversely decreased compliance, or excessive underlying metabolic acidosis. Strength can be reduced due to global decreased drive, which is usually relatively obvious in looking at the patient, impaired transmission from the spinal cord down to the neuromuscular junction, or situations of intrinsic muscle weakness. Patients with acute ventilatory failure can develop the need for intubation rather suddenly, and one way to assess the degree to which neuromuscular weakness is contributing to the patient's condition is through measurement of their vital capacity. When the vital capacity drops to less than 15 cc's per kilo, or roughly less than 1 liter, many patients will develop respiratory failure. It's important to note that patients with spinal cord injury, C345 disease, generally do not breathe well under any circumstances, but will probably do better in the erect position, whereas patients with phrenic nerve injury may do the opposite. In terms of a summarize of treating ventilatory failure, treat the underlying cause, utilize oxygen as need be, but be wary of the potential to blunt the drive to breathe, and consider non-invasive mask ventilation